Good morning, everyone. Good morning. Thank you very much. It's lovely to be here and lovely to see you all. Let me introduce myself a little bit first. We're going to talk about the curious middle ear and some clinical insights, hopefully here. So first of all, big thank you to Guy Mark, who sponsored me to come and talk to you. Views are my own. They're not on the hook for any swears or anything naughty that I say. That's purely me. And big thank you to BSHAA as well for having me again. And apologies to anyone that's heard a similar version of this talk in Manchester. But I've got some fresh things for you here as well, so I think it will still be very useful. So potted history about me, aside from my YouTube fame. I started off doing natural sciences, then went and did otorhinolaryngology PhD. You spend half the time learning how to say the bloody thing. At Nottingham, that was focused on noise damage. I'm a clinical scientist and hearing aid dispenser. I do some work for the regulator and in the education space as well. And now mostly senior lecturer at Anglia Ruskin University. I see some of my students in the audience, which is always very gratifying. And some of them are shaking their heads. You can tell if they're my students because they're going to be asleep after 5 minutes. So, a bit of exposure therapy to start us with. We're going to be talking TIMPs today. So you've just settled in, you're having your coffee, going to your workstation. It's going to be a good day. And then suddenly, okay, it's gone. Just going to put it up again briefly. Okay. Now, if you're anything like me, you see that in the morning, you're like, but my hope is we get to this stage quite quickly. And we end up maybe not quite as pally as Paul Rudd can be. Look at us. This is going to be you and Timps later. Or not, definitely not a guarantee. But I want to try and introduce it to you, explain the very, very brief history of how we got to where we are with TIMPs, explain how they work to try and demystify it a bit, because it's one of these things where, fine, we're at a stage now, thankfully, being able just to pop a tip in an ear and get a reading out quickly. There's some fascinating physics that happen behind the scenes with it. And then talk to you about how it helps us pick apart a conductive, this curious middle ear, and why it's maybe an important thing for us to do. So as we know, we deal with this wonderful sense of hearing. We have sound pressure waves that come into the ear, and they get transduced by our ear apparatus. We have our eardrum, 3 small bones, and the cochlea. And this should be moving. There should be air filled behind it, and it should be a moving tympanic membrane. So we have a suite of tools at our disposal. We can test with audiometry, and with air conduction, we're testing that whole pathway. We get the audiogram that we're familiar with, left and right ears for air conduction. But we need to try and pick this apart a bit. And so the first go-to we have is our BC. We can put the bone conductor on, it's vibrating the mastoid, and then we're able to add our BC values here. And this starts to give us a bit of an idea of what's happening with, do we have a conductive, do we have a sensory neural, is it a mixture of the two? Now, we can couple that with some otoscopy as well. Now, I tried Googling for images of safe otoscopy being practiced. You can tell this man is a medical doctor. You can tell this woman is probably a medical doctor, as is this woman. We'll settle with this one. It's probably as good as we're going to get, never mind. But let's us see and try and pick apart, because we have the BC that tells us the inner ear and the nerve beyond, and we've got our AC, the whole pathway. So by subtracting one from the other, we can say this is outer or middle ear, and this is inner ear or nerve. But we want to pick, I certainly want to pick apart the outer ear and the middle ear. We can do our otoscopy. We can see up to the eardrum and a little bit behind it. So that's letting us figure out if there's something here. If there is a huge blob of wax here or something else that shouldn't be here, we can probably assume that might be the cause of the conductive, but not wholly sure. So I want to pick this apart a bit. I want to be able to see what's going on, and I want to focus on the middle ear where we can. So again, we can subtract that out and say this is maybe outer, this is maybe middle, this is maybe inner ear and nerve beyond. People like me have existed since at least 1564. This is Bartholomew Eustache of eponymous tube fame. And then we had Valsalva come along. He named the Eustachian tube after Bart above sometime later, a couple hundred years later, and did some of the first dissections of the Eustachian tube. And he then has named after him the Valsalva maneuver, which is where you can push and breathe out. It's very useful in a weightlifting context, but can lead to a brief dip in blood pressure and a rather embarrassing faint if you're not careful. Now, we then had some subsequent work come along from Adam Polizia and then Joseph Toynbee. And Joseph Toynbee was a bit of an inventor. He gave us the first tympanoplasty, like first artificial eardrum, and some starting points in terms of instruments which aren't quite as rude as they maybe look, but might be used to open the eustachian tube. Now, our boy Joseph here had a slightly untimely end. From his Wikipedia page, he died in 1866 at 18 Savile Row, Mayfair, while conducting experiments with prussic acid and chloroform as a remedy for tinnitus. Funnily enough, isn't part of our current suite of tinnitus treatments. Either one of these substances or their combination is to blame for his death. There's worse ways to go, I suppose. He was buried at St Mary's Church, Wimbledon, and he now has a fountain dedicated to his memory as well. Here it is if you want to visit it later. Again, worse things to be remembered for, especially these days. Come the 40s, we started to investigate this in a more kind of modern scientific sense, and we had some seminal work from Otto Mentz and Knut in the 50s and 60s, and we started with instruments like the impedance bridge, and then tympanometry beginning to actually be codified in a modern sense. And thankfully, the equipment we use doesn't always have to look quite this cumbersome, nor like you could easily run someone through it on the back of a horse. But we then had work, and as we understood the results of the test better, we then had some other work which we'll come on to later in terms of typing these audiograms and having it in a readily interpretable context that could be helpful for us in a clinical setting. So we've come a long way to instruments like this one here, where we now have a handheld device. It's one click and the test is done within a few seconds. So it's a true case of standing on the shoulders of giants all the way back to the 1500s. You can read about this and more. There's a Canadian audiologist has a fantastic issue on this. It is really his niche corner, and I'll say what I say to most people when they encounter me at a party: I'm a nerd, leave me be. So in terms of how we deal with it in a modern context then, something which has fallen out of favor but something which is potentially useful is pneumatic otoscopy. So if we think back to my image of us being able to see the ear canal and the eardrum itself, it's a static picture though, unless there's something very funky going on. You're going to be looking at a static eardrum in front of you. Having the ability to introduce a small pressure change might be a useful thing to do, and it's something which, particularly if you have a Welschallen otoscope and some of the Heine ones, which are more ENT focused, they will have a little port on the side. And that isn't to tickle the patient's ear, that is to attach a sufflation bulb, and then you can tickle it with air instead. You can give it a push or a pull, and that would then let you see in real time, in a qualitative, not quantitative way, see that eardrum moving. And you might be able to see something gross in terms of, not as in but as in, is there something significant wrong in that context? Is there maybe a perforation? Is the patch that you think might be a perf, can you see it moving? Can you see the light reflex move? Or is that absent? Maybe it is a perforation. So as I say, qualitative, it's got low repeatability, but it's a start, and it's something which, certainly in some developing areas, is still used as a technique. But we can go further. Since at least the 80s, we've had the GSI TIMP-STAR, an absolute stalwart, and for NATO purposes counts as a main battle tank as well, in terms of its build quality and what it will put up with. Hands up if anybody's got one of these in department. I'm curious. Anyone? In an NHS context, these will be there. These are probably load-bearing at this point in terms of them being built into the walls of the place. Absolutely rock solid. We have desktop versions available then, and we have handheld versions, and they can be useful in different contexts. So I worked on a busy ENT clinic, and we would have a couple of the portable units stationed there alongside the big unit to do quick tests. And even the desktop units have become more streamlined now as well, with color displays, and often built-in audiometry as well. But all of these devices, whether it is a desktop one or a handheld one, they have the same kind of core principles and the same key features. So I'm now going to go into how does the TIMP work? How do we get information from the middle ear, and chiefly the eardrum's movement? We have three components in whichever system. We have an air pump, we have a microphone, and we have a speaker. Different ways of representing it. And we can measure the microphone, we can manipulate the air pressure with the air pump, and in many devices this is simply a syringe with a motor attached to it. Certainly in those larger TIMP-STAR models, you have a physical syringe in there with a gearing system. So we're interested in three factors then. We have a sound going in, we have a microphone measuring that sound, giving us an idea of its sound pressure in millivolts, and then we're able to change the pressure. And we use this odd unit of decapascals. We're not going to dwell on it, we're just dealing with principles, but be aware if you see that, that's decapascals, small changes in pressure, and millivolts, small changes in voltage there as well. So we start with a speaker. This speaker is playing a pure tone, and it's just playing it into the room. We box it off completely. It's going to be having a much harder time now moving the air. It's got a small volume of air contained, and it's really trying to push, but can't get that air to move anywhere. This is what I assume my neighbors do. They stick speakers up against my wall, playing music at 1, 2 a.m. It isn't even good music. If we make a small hole here, it's going to make it slightly easier. Some of that sound pressure change is going to be able to escape, and particularly if we then attach it to a long tube, like the tube of our tympanometer, we then have something which is called a volume velocity. This is, if you imagine, we've got a little space here. If we take a little chunk of air, this piece of air is going to be moved that way up the tube as the diaphragm of the speaker moves out, and then back again. It's going to oscillate. So we have a little kind of think of it as like a slug of air that's moving back and forth, oscillating around this point. And this is powerful. It is like a piston, and it's very difficult to stop this movement of air. It's a small unit which is moving back and forth and has a lot of energy, a lot of power, and that's our volume velocity. So there will be, at the end of the tube, a portion of air which is going in and out of the tube, and this is then what allows us to start interacting with the ear and really interrogating and seeing what it can tell us. We need to pick a particular sound, and we pick 226 hertz for adults. For pediatrics, we use a higher frequency because of the mass versus stiffness argument, which is something I won't go into at the moment. But we pick 226 hertz, so it's a low frequency tone, and this is very useful because it lets us talk in more intuitive units. We can talk in terms of milliliters and in terms of centimeters cubed when we're dealing with things like the movement and the volume later. So 226 hertz, we have this sine wave. We measured the velocity of the air at the end. It's being rarefied and then condensed, rarefied, condensed. So we're seeing this regular movement here, and it's got a lot of energy to give. If I took a big, empty orange dumpster, I drilled a hole in it and attached the tube there, that would push and pull, and that would have an influence on the air inside that container. It's an enclosed space, so that would be giving us a pressure wave. It would be pressurizing the container and then pulling a very slight vacuum on the container. So push and pull of air, and that is then generating a sound, a pressure in there, and sound that we deal with is changes in pressure. It's a sound pressure. We measure it in sound pressure level. So we do that in a large volume like this. A small amount of air, small volume velocity moving in and out is going to lead to a small pressure change. Now, if I take this, the only thing I'm going to change here is to make the volume smaller. We're going to have a smaller volume for our container, happens to be orange. If I was to put the tube in a certain person's ear, same volume velocity moving back and forth, smaller volume, we're going to have a higher pressure. It's going to sound a lot louder in this ear than it would be if we were to listen inside the larger container. So immediately we have a way of telling apart. We can tell something just by looking at the sound pressure level. We can say, okay, our volume velocity, high pressure in a small volume, and Lord knows this has got a small volume, or a low pressure in a high volume. So it's already starting to give us some information. And we can measure this with a microphone. So we can go, okay, instead of us having to directly measure the pressure, we have a microphone and we're listening. Now, consider a pediatric ear versus an adult ear, though. I'm telling you that if we have a smaller volume, we're going to have a higher sound pressure level. If we have a larger volume, a lower sound pressure level. Now, useful, fine, we can make this work. But from the clinical perspective, we don't want a potential risk of having too loud a sound or being able to have an unpredictable sound in someone's ear. So what we do instead is we go, okay, we want to actually fix this but I'm interested as a way of measuring how high the sound pressure level is in relative terms. I want to know what the correction is. Are you having to put lots of volume velocity in to get our pressure level that we want, or are you only having to do a little bit? So from a patient perspective, whether it is a child's ear or an adult's ear, it should sound about the same. It's a comfortable level if you ever had it done, and it is something that we can still get this information from without having to potentially have it sound very loud to the patient or very quiet. So this is constantly adjusting. It's being recorded in the device in terms of millivolts, and this is our way of recording what we're seeing. So we can now measure the volume in centimeters cubed by measuring the sound level with our microphone. So the microphone is letting us tell how big a space is. So that's a pretty neat thing, at least to me. I know I don't get out much, but come on. It's not the only effect, though, because it assumes there's no movement in the walls of the container. And at least one of these things moves around a lot. We could have a similar situation with a high pressure level if we had a rigid tube. So imagine that volume that we're talking about, same volume of these two things, but if one is rigid, the air pressure movements have nowhere to go. It's easy for the pressure to build up, so it's not compliant. We've got a fixed space. It's easy for us to get a higher pressure level there, versus if we imagine we put a balloon on the end of our tube instead, the walls of the container can move. They can accommodate the pressure. As the volume velocity goes in and out, it can swell, and then the pressure doesn't get as high. So now we're in a bit of a pickle because we've got these two different things. We could be looking at a high pressure and a high SPL because of a low volume, or it could be because it's really rigid. So we'd call that a high impedance or a low admittance, just the opposites of each other. Is it easy for it to move, or is it difficult for it to move? Opposite for the balloon as well. We could be looking at a situation where actually it's because we've got a low impedance, it's really accommodating, it's got a high admittance, this balloon here. Unless, of course, the balloon pops, which hopefully doesn't happen. Certainly hasn't happened in my experience clinically. Incidentally, if you've never seen this before, check this out. This is slow motion balloon popping. I've never seen anything quite this good in terms of showing what happens when a balloon pops. As my students will know, I'll go off on random segues. Anyway, so how do we untangle this then? So we have these two factors. I'm going to get my measurement from my microphone, brilliant. But I've got two things muddled together. I've got how movey, how easy it is to move that eardrum, which is the thing I'm really bothered by. But then also a factor of the volume of the ear canal, which I do want to know, but isn't my main concern. I'm more interested in how that eardrum's moving. So how do we pick it apart? Well, this is where our third piece comes in, the air pump. What we can do, we can make a situation where we know we're going to make the eardrum solid by giving a good push of air, pushing it right back against the ossicles, pushing it into the middle ear space a little bit, and removing its flexibility temporarily. So we push our air in, we give it a positive pressure, and then we could do the same with a negative pressure. We could pull it back as well. In either of those extremes, we can go, okay, in these situations, the eardrum isn't moving. When I'm playing my sound, the eardrum's still, it's static, so all of the effect is to do with volume. None of it is to do with how much it's moving with that admittance or compliance. So it lets us pick these things apart. We can tell the volume apart from the admittance, gives us two pieces of information. So we're going to build up together the clinical tympanogram. So we start with pressure on the bottom, and as I said, it's in decapascals. 0 is atmospheric, and then we have a positive pressure where we're pushing air into the ear canal, and a negative pressure where we're pulling some of it out. And the eardrum would move along with it. If it's normally functioning, it would be pushed in to the middle ear space slightly, and pulled out into the ear canal slightly. We are going to sweep. So we're going to put a pressure in, and we've just decided as a convention which way we go. We go positive pressure, we're going to put the air in first, and then gradually pull it out. So we start here, and we're going to sweep this way. So we're going to go from a positive to a negative pressure, and every second we're going to take 50 decapascals away. This ends up being incidental, but it's good to know where all these bits and pieces come from when you see the full printout. We're using 226 Hertz for our sound, and we're testing the left ear. Our other axis then is going to be milliliters or centimeters cubed, doesn't matter. And this is where we're going to have both of our measures. We're going to measure how big the ear canal is and how much the eardrum is moving on the same scale. We pressurize the air, we push our air in, we have our microphone there, and we say, right, how hard are we having to work with our volume velocity? And we get a reading. This is purely ear canal volume. Our eardrum is pushed back, it can't move, it can't flex, it's all the volume of the ear canal. We set that to 0 then. We measure it, it's 1.4 centimeters cubed, and then we set it to 0. Anything above this is now a compliance, is now how much the eardrum's moving. It's really elegant in terms of way of isolating one thing and letting us look at another thing. It's very analogous to us using our BC and our AC. We take one away from the other, it tells us a lot about the remainder. It lets us isolate the different factors. At the other end, we do the same. So by the time we get to the other end of the sweep, we pull the air out. Again, no contribution of the eardrum moving, just the effect of the volume. And you'll notice there's a slight difference. Why is that? It's because the eardrum's moved. The eardrum, instead of being like concave, or as you're looking into it, concave, it's now convex. It's now occupying a little bit of middle ear space, of outer ear space, sorry. So the volume that we measured is slightly lower. It's a good sense check for us. It makes sense. Now, it's a tiny amount, but we could see it there. That might be why. So we do our sweep, and as we go, we're measuring, and the pressure's dropping, and we plot it as we go along. So it ends up being however many individual points make it up, and then we make it into a curve. And this is the TIMP that we see clinically. Now you'll notice we have our peak, which is good. And that means that the eardrum is moving, it's compliant, and we would call this technically the static compliance. So this is how much can the eardrum move at most. And in this case, it's 1.5 milliliters. And that's on top of having zeroed it here. We've got 1.4 measured there, we've taken that away, that's the ear canal volume. Then this is the bit linked to the eardrum moving. So we've now unpicked it. We've got our two different factors separate from each other. We read across, we know that's 1.5 milliliters. That's our admittance here, tympanic membrane admittance, or our static compliance. And you'll notice as well, where is this happening? We've got our largest movement at about 0 decapascals pressure. That's exactly what we want. The eardrum, as I've said, when we give a push or pull of air in, when we're changing the pressure, if we're really pushing in, the eardrum can't move. The eardrum will move at its most when the pressure behind it is the same as the pressure outside of it. So if the middle ear is at atmospheric pressure, perfect. It's exactly what we're looking for. So we look down and we've got our peak pressure, and it's negative 25. Now there's always a bit of wiggle room, and we have our standard reference values as well, which do accommodate that. And so when we're doing it on the screen here, we just use the machine. This is what it would spit out. But what does it all mean? I've spoken a lot about this test. It's wonderful. I'm using a very outdated movie reference here, but it's one I do hold dear. How is this actually going to help us, though, in a clinical context? So that's all the preamble done. That's hopefully demystifying the machine and the process, and gives you an understanding. If somebody goes to you, oh, how does that work then? You can go, I don't know, Rob talked about some nerd stuff here. But joking aside, it hopefully explains the building blocks that have led up to it. We're doing this measurement that lets us pick apart the relative contributions of the eardrum moving and the ear canal volume, both of which are potentially useful. And a very useful thing it gives us as well is it tells us where, in terms of middle ear pressure, the eardrum is moving. So how much is it moving? What's the middle ear pressure? And how big is the ear canal volume? Now the ear canal volume, we aren't as bothered by. There's a couple of things where it is useful, but the combination of the other factors are certainly something which I think I'll hopefully persuade you will be useful. So unsurprisingly, this is going to come to the fore in a context of a conductive loss. And so we could have a case like this where we have our BC values here, and our AC here. So we have a sensory neural component up here, and then we have a conductive component as well. So what is going on? In the absence of anything else, we might be fairly limited. We could check and make sure there's no visible obstruction. We could maybe see the eardrum and see if we can see any fluid behind it. It's not always a given that you're going to be able to. But we need to try and pick it apart more, and this is where hopefully this starts to come in. So what I will explain then is we have a normal kind of reference range. So we would expect a bit of variation because of physiology rather than pathology, just different people, different size ears, different strengths of eardrum, that kind of thing. And it lets us define a kind of normal box. So this is currently in BSHAA specs. They're the main ones that we go to. There's different ones for adults and children. But for adults, we have an expectation that it should be within plus or minus 50 decapascals, and the movement of the eardrum should be within certain bounds, and the ear canal volume should be within certain bounds as well. And this is represented in the clinical equipment as well. It will show you visibly a box that we would expect the peak to be in. In a pediatric context, this is very useful as well. You can say, did you know that your ear can draw pictures? The kid goes, wow. And then you crush their expectations by saying it can just draw a mountain, yeah, or a wiggly worm. Which one do you think you're going to get? But useful thing to have. And we can then know what we're expecting. And if we then take each edge of this box of normal, we can say, okay, well, what happens if we exceed it in any one dimension? So what happens if we're below the expected compliance? That would mean the eardrum isn't moving as much as we expect. The pressure is correct, but it's not moving as much as we would expect. It's stiffer than we would expect. Conversely, what happens if it's moving more than we expect? Again, the pressure could be absolutely fine, but we could be in a position of the eardrum has way more give than we would expect with it. What's happening? Likewise, it might be moving the right amount, but maybe we've got a positive pressure, maybe we've got a negative pressure. So what I want to do, I want to try and give us a way of thinking about these fairly systematically. But unfortunately, somebody beat me to the punch, and this is this chap here called Jörger. And this is, anybody that's had any NHS experience in this context certainly will probably be aware of these classifications. So I introduced them for familiarity. It's the kind of thing where it's like, what's your TIMP type, a Myers-Briggs type situation, or perhaps a bit more contemporaneously, what BuzzFeed quiz are you kind of thing. And you should view it with the same level of curiosity, but not being bound by it. Don't read this too much, it's quite funny though. So he introduced them and said, okay, we're going to have type A, B, and C. Imaginative chap is Jörger, but it's something that we can work with. C has a massive inferiority complex compared to B or A, but we work with what we're given. You might see this in medical report terminology as well. From a medical perspective, they tend to like this type of classification. From your perspective, maybe try and be bilingual if you're reporting it. You might give it as well, particularly if it's going to a medic. But I would always take a descriptive approach these days of the results, explain what the results are saying. I'm not saying that medical professionals don't necessarily know what the TIMP is telling them. I think they have a lot of other things that are competing for their attention with it, and so anything to avoid ambiguity is probably going to really help overall. So we take our normal case. This is our no abnormality detected. Any of my students will be rolling their eyes at this. We don't say normal, we say no abnormality detected. This is our type A. This is the firstborn child that goes to Harvard. Perfect. Golden child. So no perforation. We have an ear canal volume, which is typical, and a middle ear pressure, atmospheric pressure as well, and the eardrum's moving the right amount. Now, the ear canal volume, from a REM perspective, if you're doing an insertion gain measure, is important. We know that we're in normal kind of territory. As we've moved, thankfully, long overdue to aided response measures, it's less of a factor because it doesn't end up influencing it. But being able to know that we have an ear canal volume which is typical could be useful in different cases. We could be looking at a situation of some atresia or something congenital or a syndrome, and knowing what the volume is might help us when we're doing our initial hearing aid settings. Again, think small volume, high pressure level, same as when we're putting the sound in with the TIMP. So even this tells us something, even if there's no other finding from it. We know that the middle ear pressure is correct, the eardrum's moving the right amount, it lets our focus go elsewhere. So a strong negative finding is a useful one in this context. So I'm going to give us some kind of map here. So we're going to start with this in the middle. Everything's hunky-dory. So next, what if we have a shallow, so an AS? You'll see this perhaps mentioned. So here, the eardrum pressure is correct. So the pressure in the middle ear is normal, but we've got less movement than we would expect down here. The peak isn't hitting our normal range box. We're below it. Ear canal volume is okay. The shape of the curve is okay. The pressure's okay, but we've got too low a compliance. Now this points in a few different directions, and this is where I'll start to add some of the caveats in. TIMPs are a fantastic additional piece of information. It's really useful, and I think Ancillary's doing it down. It's very good information to build a bigger picture. It lets you be more specific about something which otherwise you'd have to be quite general about if you're actually pressed on it. We could be looking at something like otosclerosis. We could be seeing a either fixation of the foot plate here or stiffening of these joints here between the three small bones. We could have cholesteatoma. We could have this thing we're always on the lookout for here. Someone showed me a beautiful picture of one yesterday that they caught. I say, again, all my expectations are well off. Long overdue thing is I once had my first supervisor describe earwax as our bread and butter, and I still can't look at toast the same. It could just be a thicker tympanic membrane. There is variation in terms of the structure of it, and we have this thing, it's a topic I haven't gone into in detail here, but you have this thing of whether it is mass or stiffness dominated. It's why we use the lower frequency sound, because we're more bothered about the stiffness of the eardrum. But if it is a more massive, in a true physical sense, if it's a more massive tympanic membrane, it could influence results, and it could be harder to move with that fixed pressure. So we put that down here. We might end up in this territory here, and that might mean a medical referral. It might get us to look even closer at the TM and see if we can see anything. We might factor it into our fitting decision. We might be thinking either fitting formula using those conductive top-up, or we might be thinking another device. Opposite then, what if we have a deep tympanogram, so an AD in this context here? Again, ear canal volume is fine. The shape even, as far as we can tell, is fine. The pressure is fine. It's just it's hypercompensating. We've got this massive peak here. So what's going on? We could be looking at a situation of some articular chain discontinuity or dislocation. So it could be that it's become unstuck, or it could be that it's become fractured. So a common thing that you can see in road traffic accidents is this dislocation. Here's an example of a CT where that's happened. So you can see we've had two examples here. This is a malleoincaudal dislocation, so between the malleus and the incus, that's become detached there, and the stapes is displaced. That's a really bad one. Or just a dislocated stapes here, so that's come away from where it should do. And you can see the eustachian tube just going through there. That's heading down into the nasopharynx. It could be that we've got an area of weak tympanic membrane. So this is where maybe that traditional pneumatic otoscopy might show us whether there is a perforation or not. This helps to build the case that it's not a perforation, and we know it's not a perforation because we've got a normal ear canal volume, and we've managed to measure a peak with a pressure as well. We'll come on to that later, what happens if there is a perf. So this is showing that maybe we do have an intact eardrum, but maybe a patch of it is weaker. You sometimes see this as a double peak on the tymp as well. One piece has a certain stiffness, and another area, maybe a healed perforation, has another bit, which is easier to move or harder to move. So again, it helps build a picture. It helps give reassurance of some of our other findings from otoscopy, and helps to build up a picture from a conductive perspective as well, maybe. So we've mapped out one of our axes then. We've got our normal. What happens if the eardrum's moving too much? What happens if it's not moving enough? Either of which could cause issues. So let's start talking about pressure then. What happens if we change this pressure, or we observe a pressure which is different to atmospheric? Well, then we're looking at a type C. So C in this context, middle child, often forgotten. Pressure in the middle ear here is too low. So the eardrum, if we were looking, it can be pulled in, it's retracted. And we might see this on otoscopy, a very kind of notable case here, but I think we've all seen something like this if we've been in practice for a bit. that eardrum is pulled back and shrink wrapping the middle ear ossicles. You can see the malleus here very clearly. That might be the edge of the kind of cochlea there as well, and that might be one of the tensor tendons there. So you can see it's really pulled back. It's telling us information though. We do have an appropriate ear canal volume, and that tells us that there isn't a perforation. We have got the eardrum moving an appropriate amount. Now it's slightly at odds with what I said to you earlier about us really giving it a good push or pull, but you'll notice we're not quite as far as we maybe were pressure-wise when we were testing. If you really give it a push in one direction or another, that's not going to be painful. It can really isolate that movement. But you can see, and we'll come on to it in just a second as well, it's going to start impacting the movement maybe a bit. But right now, as we've measured it, the eardrum is moving the correct amount. There's just this negative pressure behind it. So, common thing, most common by a mile in adults, is a start or recovery from a cold. It could just be that we are getting over something, we're getting over an upper respiratory tract infection, and it's just part of the kind of adjustment back to that. If it's persistent, it could be eustachian tube dysfunction. It could be that it's not opening as often as it should, and that middle ear space, which should be periodically ventilated, it's not happening often enough. Now, it wouldn't normally affect hearing. If the eardrum's still moving, this can still mostly do its job in terms of transducing the vibrations and sending them through to the cochlea, but it might explain other symptoms. It might explain any kind of fluctuation the patient might be feeling, or a feeling of fullness maybe, particularly as it's the kind of thing that could come or go. It could be that they've just done some diving, or they've just come off a flight, and the middle ear hasn't had a chance to equalize pressure yet. It could be a hint of something very simple that we can do to maybe help in that regard. So we have that type C over there. Negative pressure, everything else is okay, just one factor messed up. Compliance on this axis and pressure here. So then type B, the wild youngest child. The way has been paved by its elder siblings. This could really be anything, it's all over the place. So no eardrum movement measured here at all. This one isn't even playing the game. We don't have a peak to measure our pressure from. So what can we tell from it? Well, we at least have an ear canal volume. And this gives us a couple of subtypes of a type B actually. So there's no pressure measured, there's no compliance measured. So we can't say anything about the eardrum's movement. It could be it's not moving. It could be we're blind to it because of circumstance at the moment. So we can check our ear canal volume. If the ear canal volume is normal, this is strengthening the case for the eardrum actually not moving. We know that we've measured up to that eardrum okay, we've been able to partial out its contribution, and we know that we've got a seal at the right level. We probably don't have a perforation in the eardrum. We're measuring the eardrum's true movement, and that movement is nil. It's not moving anywhere. We're not getting anything above that volume that we measured earlier. So the most common thing here is middle ear effusion, or glue ear, as you sometimes hear it called. Extremely common in children. Virtually all children are going to have at least one bout of it before the age of 6, and usually at about the age of 6 or 7 they grow out of susceptibility for it. Here's a picture, if you haven't seen one recently. What you normally see, it's its classic kind of appearance, is you typically lose the cone of light, but as you can see, not necessarily exclusively. You might see bubbles up at the top as well, if the fluid level isn't completely filling it, but this kind of ambery kind of liquid behind there. And what will normally happen here is it will develop in this space, and the reason it affects children more than adults is in craniofacial development, this bit happens quite late. The eustachian tube starts quite flat, quite small, and quite floppy. So it makes it harder for it to open as often as it should, and if it does, you don't have gravity aiding any draining of anything that is there. But by the time you hit 6, 7 years old, this development's happened, and for most cases then, you're like middle 50%. This has developed to a point where, unless there's any other pathology going on, that can help clear it. It also explains why this still remains common in some syndromes. So trisomy 21, for example, Down syndrome, it's a very common thing, very, very common to have this here, and that's partially because of the abnormal craniofacial development that happens there. This eustachian tube step doesn't happen in the same way. They're still very vulnerable to getting glue ear, so it's something we need to think about in a clinical context. Now, we can link this to our other audiograms, there's a typical profile that tends to happen, and that is the middle ear space isn't being ventilated as often as it should. It's lined with the same kind of cells you have in your nose, and they're respiring. They're eating up things and then spitting out gas. But what ends up happening is they end up using up some of it, and it ends up slowly developing a negative pressure. And so you see, from a normal case here, if we imagine an onset of a cold or eustachian tube being blocked up, we're about to go into some glue ear, we might see an A gradually decline. We're seeing the pressure become progressively more negative and the eardrum moving less and less and less until we hit a point of it not moving at all. And this is a common thing that you will see in a pediatric context. You will see either the patient will get respite because the eardrum will burst and the liquid will come out. Oftentimes, actually quite a relief. Any pain of the eardrum being ruptured is outweighed by the pressure relief, and usually the only thing that will be noticed is in the morning a big mess on the pillow on the bed. You might not even wake in sleep with it happening. Or alternatively, the eustachian tube does open and the liquid drains out. So you would see in a pediatric context, and some adults as well, you see the cycle of going through here. So we get progressive negative pressure, the liquid gets pulled out of these tissues here as well. So you start with a negative pressure, it pulls that kind of thin liquidy mucus out of those tissues to begin with. And it can be anywhere from very thin like water through to thick like glue. It's where the term originally came from. It's meant to look like Elmer's craft glue in the States or something. Apologies to any Americans in the room. And then something happens where it resolves and you go back to this state. So in a management context, a grommet is an option that sometimes happens. You can put a deliberate perforation in that eardrum to stop any buildup of any negative pressure or any fluid, but they tend to fall out quite quickly. It tends to last for maybe a month to 3 months. So it's only temporary respite. So you might adopt an approach of watching and waiting, and you might say, okay, as long as the child is getting some respite from this, in the summer months, for example, where upper respiratory tract infections are maybe less common, we can maybe forego the need to do surgery. We can maybe do this, let them catch up with speech and language development in that time, and see how we're going. So it's why oftentimes you take a community pediatric approach with this, and you might look over 2 or 3 visits to see what the profile is over time before rushing in. So that's what happens if the ear canal volume is normal. But what happens if the ear canal volume is high? So this time we've got exactly the same trace, but our ear canal volume is reported as 3-4 centimeters cubed. Well, instead, this is indicating that we're not just measuring the outer ear, we're actually measuring the middle ear as well. There's a perforation, more than likely, and it's allowing air to port through into the middle ear. So when that volume velocity is moving, it's got that whole bigger space to interact with and change the pressure of. So the pressure is going to be lower, and so it's going to measure a higher volume. It can't see, at that point, potentially, the eardrum. In the same way, it can't really see the ear canal wall. The eardrum just becomes, at a certain point, an extension of the wall, with the bounds of the box. We're just measuring the volume. So that's why we have no contribution of the eardrum here. It's just volume. And we see a bigger volume. This can be really useful from the point of view of showing, yes, there is a perforation. You might not see it with otoscopy. It might be a pinhole perforation. But again, it's a little bit variable. You could still see a peak. You will measure that a larger ear canal volume. You might still have a peak on your trace. It could even be a normal peak, but we always keep an eye on the ear canal volume, because if it's high, there's very other, aside from faulty equipment, it basically has to be a perforation. And it could be near total, which makes a lot of sense. But it could also be something a bit smaller, or even very small potentially. So again, really useful thing to tell, and something we wouldn't necessarily be able to do just with our otoscopy. So here's a situation where it might be, we might still measure a peak. You can see we've got this slightly ragged perf here. It's in the past tensor though, probably safe. It looks nice and clean. So we're probably going to get a peak, but also probably a larger ear canal volume than we'd expect. So we add that to our list. We've got a B high there as well. Now what if it's low? If the ear canal volume is low, very simple one in this case, something's blocked. It's either the ear canal is blocked with wax, or more than likely, we've got those 3 little tubes, all have to go into that space at the entrance of the ear canal. It's probably just that's blocked with something. But an important thing for us to check, an important sense check, and something that I always impress on students to make sure they double check as well, because you don't want to send someone away saying that they've got a blocked up ear when it's actually the instrument that's blocked up instead. So easy one to check and a useful thing as well. Just means a repeat measurement's needed, or we might need to do some de-waxing. Yeah, satisfying. Anyway, so we have our set of results then. And the measurement itself, as I say, it's very quick to do. And I think it gives you good supporting diagnostics. I would count myself as an evangelist for the use of TIMPs. If not entirely routinely, then as soon as there's an indication of anything fluctuating or anything conductive, anything where we think there might be some middle ear contribution. But it's the kind of thing, if you get into the habit, if you have one on hand, you get into the habit of doing it, you're adding maybe a minute to your patient experience with potentially some very useful data. If not now, then in the future. You could compare this down the line. Each patient has their own kind of spot on the graph in terms of normal, and being able to compare a patient's tympanogram from a year or two before might prove very useful in the future if something does happen. It can help explain oral fullness. It can help you figure out the state of someone if they've got a cough or cold, whether it's likely to impact on the hearing test. It's part of our case history, or should be. We're asking about if we think the patient has a respiratory tract infection at the moment. It might help us understand. If we get this and a small conductive on our audiogram, we might go, right, we'll test you again when you're feeling a bit better. If this is reporting a type A, we might go, there might be a little bit more to this. It might help with these repeat visits or testing then, and might help with referrals, which we'll come on to in just a second as well. And as I say, it's only a 30-second test. Would you like to see one being done now? Yeah? Let's do it. I have a fabulous volunteer here. Thank you very much. Let's give her a round of applause. Come on. Perfect. So thank you very much. So in terms of doing the test then, it is effectively a follow-on from otoscopy. You do your otoscopy first. You'd be asking the same questions. So any infections, any pain, any operations, any discharge, any current treatments for the ear, that kind of thing. You'd be double-checking the surgical side. There's a rare case, if surgery's happened recently, you might move things a little bit, but 3 months is fairly safe, and you just consult with an ENT if someone sent them from that kind of context to you. We'd brief the patient by saying, okay, this instrument is like having a look in your ear, but it's going to give a push and a pull of air, kind of like when you're on a plane, but not as severe, and you might hear a little sound from the instrument as well, and it shows us how the eardrum's moving. I haven't had anybody scream when I've explained it to them like that yet, and it's a good way to kind of couch and set expectations. Any problem at all, let me know, put your hand up or move away, and we'll break the seal. Is that okay? And we carry on. So the instrument itself, turn it on, it's entirely battery powered. There's multiple different versions of this that exist. And this form factor is pretty good, particularly if you need portability. But otherwise, you would have the body of the device would be on the desk with the thing changing the pressure and that kind of thing. And you just have the tubes going up to an earpiece, which you then hold like that. So we select the tympanometry. And do a fresh measurement. We did one earlier, blue Peter style, but I'm confident we can do a fresh one. And then we attach a disposable tip onto the end as well. So similar to your otoscopy tips. And so what we do is we position it like that. We brace appropriately. How was that?
Good.
Good, thank you. Better than my usual reviews. And that has then given us the trace there. It's literally that quick. You do that per ear, and then we have our trace, and we've got our details on there. We've got our pressure, which is negative 11 decapascals, very good. Ear canal volume of 1 milliliter, perfect. And compliance of 0.4, you were the perfect patient. Thank you very much. So I'll hand this around, do pass it around the room. If you want to have a look, see the result in there as well. And then tip just comes off, and that's it. So it is literally just the front loading from an equipment perspective, and then seeing how it fits with your flow. But it's something that should be present at some point in the patient kind of journey. If you're seeing patients downstream of a GP with special interest, maybe not as important. If you're the main person the patients are seeing and responsible for the direct referrals, I would argue increasingly it's something we need to be paying attention to. Now, forgive the not quite legible, but this is from BSHAA's Professional Guidance Handbook for onward referral. And there's a few things here I draw your attention to. One is fluctuating hearing loss not associated with an upper respiratory tract infection. This helps in that regard, in terms of being able to say whether it's associated or not. We get that from the case history as well, but it can help back you up. You've got the other point there just below it as well, which is middle ear effusion in the absence of or that persists after a upper respiratory tract infection. This is really where it starts to come into its own. You're able to demonstrate that middle ear effusion, you can document it, you can show when it's there and when it isn't, versus just a visual assessment of it, which may or may not be accurate. Even with the perfect, even when I do the otoscopy, I might get it wrong. I was wrong once in the 90s. I've never forgotten it. I lived it down. The other thing that I draw your attention to as well is this one here. So it comes from NICE guidance and has been incorporated into our local guidance now. So particular ethnic origins, so Chinese, Southeast Asian, North African, Inuit or Yupik, we need to be particularly careful because there's a higher risk of nasopharyngeal carcinoma in that population. So what can happen, particularly if you have a unilateral, persistent, flat tympanogram, that can be an indicator that there's something growing in that nasopharynx behind the nose space or behind the throat space. And this could be the main presenting factor of it as well. So if nothing else, increasingly becoming very important to offer equitable care to patients of all demographics. It's a risk for other demographics. It's not one that happens to hit a Caucasian population, but it's one that we should be aware of, and it's one where we should be doing this to offer equitable care irrespective of origin. So hopefully I presented the case for TIMPs, why I think they have a strong place in kind of contemporary practice as well, and the different results that it can give us and how it can aid interpretation. And given that the test itself takes about 30 seconds, it's relatively painless as well, and is effectively just an extended ear exam with otoscopy, I think it's a pretty good deal. It's one that I would make, certainly, and one that I would advocate for. So, got time for any questions if there are any. Be very happy to take some, but otherwise I'd like to say a big thank you to BSHAA for having me again. It's an absolute pleasure, and it's a meeting I really, really do enjoy coming to. And big thank you to Guy and Mark as well, who are over there. Do have a chat with them about the equipment. And yeah, thank you very much for listening, and thank you very much for your attention.
Thank you very much, Dr. Rob MacKinnon from Anglia Ruskin University, everybody. Thank you so much, Rob.